Good morning, fellow doctors and fellow colleagues. I'm Dr. Beverly Libo-on. I'm the Monitoring and Evaluation Surveyor of Healthy Futures Global. We are an NGO trying to make a difference in the lives of pregnant Filipinos. So let me introduce to you a little bit about our NGO. So we are actually a US-based non-government organization. And our organization wants to offer free medical training and free medical kits because we are all on the same mission. We want to give every child a healthy future. Now, we are here today because of the invitation of our Provincial Health Officer, Dr. Pinongan, thank you so much, and Dr. Fama. And also, we are here because we can save thousands of Filipino lives. And also, the Department of Health can save money by preventing rather than treating the disease. Our study is focused on syphilis. And as a review, I know we don't really have to go through this in depth. Syphilis is an STI, and about 1 in 50 pregnant women, or pregnant Filipinas especially, have syphilis. In fact, the Philippines was one of the top 2 countries we looked into to conduct this study. And this is how we found out that 1 in 50 pregnant Filipinas have syphilis. Syphilis can be life-threatening for both pregnant Filipinas and their children, especially in the form of congenital syphilis. At least 3 out of 4 women go unscreened for syphilis. A pregnant woman with syphilis can infect her child during pregnancy, resulting to multiple complications, even death. This equates to 15,000 stillbirths or newborn deaths every year. Managing syphilis is very familiar to all of us, and as you may all know, it often does not present with any symptoms. Hence, all pregnant women should be tested, even if they do not have symptoms. And it is part of our national guidelines to test pregnant women with these STIs. Now, these pregnant women who are positive for syphilis can be easily treated with 1 dose of penicillin G. Pen-G is relatively inexpensive and, most of all, it is safe for pregnant women and their children. There's been several studies which have shown that dual testing for both syphilis and HIV in prenatal care can save lives, costs, and time. So our study utilizes a dual kit which tests for syphilis and HIV, a dual syphilis HIV rapid testing kit. I do not have the sample right now, I'm so sorry. But it is a dual kit, so we test the patient at one time and we see results in 15 minutes in just one kit. So the dual HIV syphilis test kit has been endorsed by the World Health Organization in 2019. So why should we conduct this study? First, we want to convince the Department of Health that providing training and medical equipment, especially the dual HIV syphilis rapid test kit, are efficient or effective ways to save lives in our country. However, before rolling out the dual HIV syphilis test kit across the Philippines, the DOH asked our organization to conduct a study to prove effectiveness. And secondly, we would like to supply and capacitate primary healthcare facilities in syphilis testing and treatment. Rather than referring pregnant women to follow-up facilities where they usually cannot go due to several causes, usually logistics, transportation costs, we would like to create an effective system where pregnant women can easily receive care with less cost and effort. So where precisely in the Philippines are we conducting this study? We have selected areas for our pilot basing on 3 general criteria. First, we're looking into places with the highest number of pregnant women. Second is areas with the lowest percentage of testing. Thirdly, areas with the highest syphilis prevalence. And we have found out that areas all over the country, such as in Antipolo, Bulacan, Negros Occidental, Cebu, and in Mindanao, Lanao del Sur, and Maguindanao are viable for our study. Now, we chose these areas through several mechanisms. First, at the province level, we use province level FHSIS data, which are publicly available. And with these, we were able to identify areas with the highest and unaddressed burden of maternal syphilis. Secondly, at the municipality level, the DOH endorsed us to the provincial health offices through their corresponding CHPs. The PHOs then provided us with FHSIS data of their municipality with the highest and unaddressed burden of maternal syphilis. And lastly, at the barangay level, the CHOs and MHOs identified barangays that had the greatest need for this intervention and the capacity to support this study. Now, for Negros Occidental, we chose for our pilot 3 LGUs. We have Escalante, Kabangkalan, and Sagay. Because we base this on the public FHSIS data that these cities have the highest number of undetected syphilis cases, the highest number of eligible population per week, with the lowest screening rates and the highest reactivity rates. Now, this study will not be possible without your help. So we will require consent from all parties. Firstly, pregnant women, we will need their consent. They will have to provide their consent to get tested for HIV and syphilis in confidentiality, of course. And we would ask them to participate in the study, including a potential interview. The clinic staff will have to ask them if they want to participate in the study, including potential interviews. And of course, the clinic heads, our city health officers, our municipal health officers, to consent to the clinic, asking for consent from the clinic and the staff to participate in this study. We would like to capacitate more facilities. So currently, in most LGUs, what happens is that when a pregnant woman comes in, for her prenatal care, she generally has to visit 3 facilities in order to receive syphilis testing and treatment. Usually, they would approach a primary clinic first, usually a barangay health center, and then will be referred to their social hygiene clinic or their main maternity clinics for laboratories or preferred OB-GYN in their district hospitals or their private OB-GYNs. And then, if the patient is positive for syphilis, the local physician treats. Of course, with HIV process, it's different, but in general, this is how it would look like. Now, what we are trying to do is we would like to equip your LGUs with the necessary goods and training so that a pregnant woman gets tested and treated on her first visit. So, cutting all the other travel that the pregnant woman will have to go through without this model. Your LGU can become part or become a leader in maternal health with us. What we want to achieve are, we want to conduct the study in over 6 clinics over 6 months, conduct 300 interviews of staff and patients, get around 3,000 women nationwide tested, have around 60 women treated, and avert 20 perinatal deaths. If we get to enroll your clinic, you will receive medical goods such as 500 dual HIV syphilis tests for this pilot, and penicillin G, we will provide it for you for free for treatment of syphilis reactive patients, pregnant women in this study. We will also provide the training, particularly on counseling, pre and post-test counseling, testing and treatment. And we will also come in for ongoing mentoring for your staff and, of course, data collection. So we are a startup NGO. We're comprised of, we're actually 6 now, sorry. So we have our executive directors, Kayer, he's a doctor, he's based in Australia. Nils, he's based in Germany. And our program manager, Joseph, myself, and our colleague Goldie from Mindanao. So, help us lead the way to prenatal syphilis testing. If you have questions or concerns and challenges, we'd be happy to discuss it with you. We would also ask if you can endorse our study to your mayor or your city health office. And in the future, once we have succeeded with the pilot, we can continue our collaboration to give all pregnant women in Negros Occidental access to testing and treatment. But before I end, I'd like to further discuss the technicalities of our study. So, our NGO is non-profit and we are registered in the US, as I have mentioned. We are officially partnered with the Department of Health through the Evidence Generation and Management Division of the Disease Prevention Control Bureau of the DOH. We are also currently partnered with the UP NIH, some of the research advisors, and we are also collaborating with the WHO Philippines Country Office. We are also working with the device manufacturers and suppliers of our kits, but we have no financial or legal association with any commercial entity. So, what about, we might be asking, what about our patients, their partners, their sexual partners? What happens to them? So if a woman's test shows syphilis or is syphilis reactive, her partner should be ideally treated and no testing is needed. This is a WHO-approved approach called the presumptive partner treatment. Why do we have to treat immediately without testing? Because there is a risk of false negatives for the partner, and there's a potential of re-exposing the baby to syphilis. However, pregnant women are encouraged but not required to tell their partners because of the confidentiality as well and respect to the pregnant woman and their partner. However, treatment is free for partners of women with syphilis. So, the pregnant woman is reactive for syphilis. If her partner is also reactive, we also treat them for free as well. So, you might also be concerned with data and confidentiality, data privacy and confidentiality. So, we'd like you to know that we are working with DOH, and our study protocol has been approved by the DOH's Single Joint Ethic Review Board. Our protocol ensures confidentiality, wherein our team will never record results of HIV testing. So what will reflect on your record will be that the patient was tested for HIV, but no results will be gathered from our end. We will only collect data if the patient provides written consent. We will also anonymize the data by not recording their names. However, we will use identification numbers. And these identification numbers will not identify the patient's personality in itself. And we will not collect additional health data compared to standard practice. So we want to make the study as organic as possible, wherein we will still continue with what our usual practices are when we interact with our patients, history taking, physical exam, and so on. The difference is that our team will conduct interviews and assist you with any troubles you have with regards to the study. So, what data will we collect? So, facilities will only continue to collect the health data that they are already gathering. The only difference is that a monitoring and evaluation surveyor, in this case myself, will come into your facility every week to interview pregnant women and healthcare staff on their perception of syphilis testing. So we will not be interviewing on your patient's result if she was syphilis reactive. What we are trying to gather here is their perception on our testing method. Again, people will not be interviewed unless they give written consent, and the interviewees can withdraw their consent at any time which will cause the complete deletion of the interview data. Healthy Futures will also not record patients' names and addresses. We will only collect data on the aggregate, that is, the number of pregnant women tested and the number of pregnant women testing positive for syphilis. Test results will only be linked to a study ID number, as I mentioned, and there will be no way to connect a specific test result with a specific patient. And HIV test results will never be recorded by Healthy Futures, as I mentioned. So, what if you want to discontinue in the study after a certain time? You are in control. You can withdraw your clinic from the study anytime. The surveyors will interview your staff, will also interview your staff regularly to detect and mitigate any issues if they arise. So, our sampling method, we will be collecting quantitative and qualitative data. So for quantitative data, we will be collecting the number of positive cases, so that includes the patients who were included in the study unless they do not consent. And those who decline to participate in the study can still get access to free testing and treatment. So even if they decline to join in the interview, if they test positive for syphilis, they will still receive treatment. And for qualitative data, we will be conducting anonymous interviews. Here, we will collect it from a subset of patients. And those who decline interviews can still get access to free testing and treatment. Okay. So our inclusion criteria generally are women with confirmed pregnancy who are coming in for prenatal care, ideally they're first, and are willing and able to provide valid informed written consent, and would be from between ages 15 to 49. However, pregnant women under 18 will require consent of their parent or guardian, but can still access testing. And our inclusion criteria will be those pregnant women who already had HIV and syphilis testing in this pregnancy, and those who do not give consent. So our study design is interventional, not observational. We will be conducting a pre-post analysis. So we will try to determine what were the testing rates first, in the first 12 months before the study, hence that's why we would ask for the baseline data. And over 6 months, what are the testing rates after we have introduced rapid dual testing. And our interviews will follow thematic analysis, where it will try to answer what were the main themes that have emerged from the interviews. So that's an example of how we would like to look at it with the graph there. So why do we have to treat or test 3,000 pregnant women? This is actually just a conservative sample size calculation which we have based on our hypothesis. So assuming a p-value of 0.05 and a power of 95% chance of detecting an effect, and assuming a 1% syphilis prevalence and 50% baseline testing with an effect size of more than 20%, point improvement in testing and treatment with an inclusion rate of 68% of eligible pregnant women. So, what would be the outcomes of this study? Our primary outcomes would be what are the syphilis screening rates and what are the syphilis treatment rates. And our secondary outcomes would be to identify qualitative insights such as benefits of rapid testing or other ways to improve. Identify the prevalence of syphilis in pregnant women and the number of partners of pregnant women treated. Our donors historically have been private donors, mainly, who are interested in cost-effective global health NGOs. Most of them are anonymous, but they are donors worldwide, primarily from the US and the EU. And however, we are looking forward to receiving more grants from other foundations, and we're working on them. And also grants from other international governments and private foundations. And that's the end of my slide. So I actually have here our Executive Director, virtually, and my project manager, Joseph Iwan. If you have any questions about our study, we'll be very happy to answer them for you. So if you have questions. If you don't have any other questions, thank you so much, and we are hoping that we can work with your LGU. I'd like to thank Dr. Hinolan, Dr. Junto. I'm not sure if Dr. Junde is here. Thank you for receiving us in your CHOs. Yes, Doctor.
Criteria for choosing the
Yes, Doctor. We had several criteria. We were basing on a high syphilis prevalence, a high number of pregnant women who could potentially come in for prenatal, low testing rates. So these were our top criteria. Really. Testing in pregnancy, yes, during prenatal, of course. If we can remember, part of our efforts for the implementation of the Universal Healthcare Law is the PMPCP of syphilis, Hep B, and HIV. So we're also trying to become part of that goal as well. Yes, Doctor. Yes, ma'am. Sorry.
The testing is goal for one test.
Yes, ma'am. It's one kit. It's a rapid testing kit. The same principle with our usual syphilis testing kits. Ang rapid, not the RPR. So, but however, it's two tests na. So you just test the patient in one setting, and then you get two results. So you still have the control, and then syphilis test result, and then the HIV test result. If the patient does become reactive for HIV, we will follow our HIV treatment algorithm. Yes, Dr. Maria. Yes, Doctor. Good question, Doc. We're still at the pilot stage. So if the pilot succeeds, we are definitely looking into expanding to more LGUs beyond the three we have first identified. So we're really looking forward into expanding, hopefully, all. Hopefully.
So I would like to suggest that you should please consider other poor municipalities like Don Salvador, Benedicto, because if you're going to choose the LGU based on the number of syphilis testing, I think Don Salvador would not qualify in that criteria because all of our patients, though it is very rare for our patients to apply for a RPR test for HBs aging. That is why, and that is probably the reason why, that we have no cases of syphilis because our patients cannot afford to be tested. So I'm hoping that your NGO would also consider DSP as one of your benefactors.
Yes. Thank you, Doctor. We are also looking forward into expanding to other LGUs, particularly those who really need the assistance. But for now, because we are at the pilot stage, we want to conduct the study in an LGU that has the best inclusion criteria, the best criteria as much as we can, so that we can ensure the success of the study and then potentially include other LGUs as well. Thank you, Doctor. Yes, yes.
Is your deliverables of 3,000 for Negros Occidental alone or for the whole?
This is nationwide. Yes. So we are currently we're starting with Antipolo and Marawi. I think this week we've already started, and hopefully Escalante this week or next week. If you don't have other questions, Doctor, you can always you can always reach us. Our website is healthyfutures.global. I've also left my contact numbers with the PHO office if you have any questions or clarifications with our project. We will be very happy to work with everyone, and we are looking forward to working with everyone in the future. Thank you so much.